Good afternoon, everybody, since it's 12 o'clock. How are you doing? Doing well? Thank you for coming. This is the first in 4 of a series of lunch and learns that we wanted to do around best care. Dr. Callender and the EVPs were discussing one day, how do we get the message out in a more clear way so people really understand the message, they can help communicate the message, and they have a better idea of how the goals that we have for best care, how they can make a contribution to it. So we're trying to work this into a simpler message. We have, as one of the folks who was helping me with my presentation, when I substituted a word for another word, reminded me it doesn't specifically mean the word that I changed it to, but I think we really need to try to simplify the message better and think more about how we can engage everyone in understanding what not only best care is, but in better understanding how they impact best care as an employee. We're going to have 4, as I mentioned. They're going to all be in Leavenhall Dining Room. We're going to serve a light lunch. Although chips and a big old sandwich, I don't know how light that is, but it'll be good. Next week, we're going to have Dr. Sharma, who's our new Vice President and Chief Medical and Clinical Innovation Officer, is going to talk about clinical documentation improvement and reducing UTMB's mortality rate. So I think there's a lot of good information here, because if we're not doing well on our mortality rate, people may think, oh my gosh. But when we look at what's the care we're providing versus what are we documenting, it's a different story. So I think he's going to walk us through how do we explain this to the folks that we work with. On January 31st, Dr. Kirschbaum is going to present Reducing Preventable Readmissions and Improving Patient Safety. Again, talking about what does that mean and how do I contribute to that improvement. And then the 4th Lunch and Learn will be on February 8th, and it will be Reducing Length of Stay and the Patient Resource Optimization Program. And Deb McGrew is going to talk about that and what some of the barriers are at times in getting patients discharged, and what are some of the things we can do to better plan for that, and how, again, can an individual help make sure we meet our goal. On February 2nd, Dr. Callender is going to do one of his town halls. And in this, he's going to talk not only about the strategic plan, particularly talk a little bit about the clinical strategic plan, but we'll address some best care issues as well. And then I wanted to remind everybody, for people who are in departments with people who were unable to attend, we are streaming all of these sessions so that people can watch from their computer, and we're recording them as well so that they can be watched online when people have an opportunity to do that, perhaps even in 10, 15 minute segments as they're having a quick lunch break. So today's agenda, I thought I would start with a bit of an overview, very brief, about best care, and I'm going to talk about equity of care. When I'm finished, David Marshall is going to talk about patient-centered care, and then I think he said he wanted to know which slide I was starting on to bring it home, so I'll be bringing it home, and then he and I will be available for questions. What is quality health care? And that's really what this whole initiative is about, is how do we to the external public report on the quality of care here in an accurate manner? And so several years ago, we talked about what is quality, and we tried to come up with a simple definition that could resonate with everyone. And for us, we decided to settle on quality of care is delivering the right care at the right time to the right person and getting the best possible results. We said every patient, every time. And that's really important, because as a patient myself, that's what I expect. I don't expect mistakes or errors, and that's what we want for all of our patients, this defect-free care that we're able to offer them, and it's the right care for their condition. And so it's that quality, that level of quality of care that we are talking about, and we call that best care here. Now, I wanted to remind us of how we're measuring ourselves, because that's important in terms of the Chancellor's Challenge. Do you remember, does anybody remember what the Chancellor said we needed to do? That we've coined it now best care, but there was a ranking we needed to achieve. Do you remember? Anybody remember what that was? Top 20, yes. Boy, lots of people. Good. Great. So we're to be in the top 20 of the academic medical centers that report their information to a company called Vizient, which used to be University Health System Consortium. And they have a quality and accountability study they do every year, and they look at our data compared to others. And then they rank us in one of 4 quartiles from 1 all the way down through 102. Our rank last time was 76, so we're in the 3rd quartile, which is lower than even the middle ground. So we started really looking into that, because we could maybe address all of the areas they measure: mortality, equity, patient-centeredness, safety, and efficiency. But if we don't really target where the issues are, we may or may not make improvements. And if we do make improvements, we don't know really why we made them. And the same would be true if we don't know why we didn't. So you're going to hear over the next few sessions some of the emphasis that we're putting on each of these areas. So for mortality, we identified that documentation, appropriate documentation for this, how ill the patient is, isn't always there, or isn't there in ways or wording that is accepted by the payers. And so we could have a very sick patient, but unless we documented all of the other conditions that they have that make it a more complicated patient, the code reveals that we're just taking care of a patient with a very easy outcome. So why did the patient not fare well? So we need to really work on that. I'm going to talk about equity, and David's going to talk about patient-centeredness. But in efficiency, we're going to be looking at adjusted lengths of stay, use of resources. In other words, how much does it cost us to deliver that care versus people or organizations and academic centers we can compare ourselves to. And then safety is really talking about what are preventable events, things that if we did better, we could have prevented that in the hospital. Could be infections like a catheter infection for urinary tract. It could be a hemorrhage. It could be pressure ulcers. It could be falls with harm. Those are all the things that we really want to focus on to make sure that we're delivering the best possible care. The percentages around the circle with each one of those represents what percent of 100 that this score carries or is weighed in the outcome of the quality and accountability study. So equity is 5%, efficiency is 10%, patient-centeredness is 15%, and then mortality and safety at 25%. So you can see where the real emphasis is, and our need to, in some of the lower performing areas of those, if we would just address the major issues, we would bring ourselves up into that top 20. I also thought I would just mention before I go into equity, how are we doing so far? So if we look at the areas that we are trying to improve so that we can get to that top 20, HCAHPS, who can tell me what HCAHPS is? What is that? What does it measure? patient satisfaction. It's the patient satisfaction tool that is used and approved by the government with 8 questions that more or less that patients respond to, and then we see how we're doing. You'll see for this quarter 1, we ended at 81.6%. Our goal was 76.4. Next quarter's is 76.4 because these were all predetermined goals by quarter. And so what we need to do is just keep moving that up. The more we move it up, it will help us if some other metrics don't move as much. In readmissions, we're actually doing well. We beat the quarter 1 goal and have already barely beaten the quarter 2 goal. More to come as we have in quarter 2 now experienced some issues with bed availability due to the fire, but we're hoping that we're managing the patients in a way that we don't have unneeded readmissions or readmissions for which we are not paid. You all understood that if the patient's discharged from the hospital and they return within 30 days, Medicare doesn't pay us for that readmission. So it's worth dollars and dollars and dollars. Mortality, our goal was 0.99. We were at 0.91. Have to continue to make improvement there because next quarter is 0.90, and each quarter is going to get harder. We set them so at the end, the 4th quarter, it's the most aggressive target, but we need to get there to be in that top 20. The AHRQ PS90, I mean, isn't that the topic of every cocktail conversation you've had? Yeah, let's talk about that. And I said, it looks like alphabet soup, but it's really, this is a combination of a bunch of different patient safety indicators that rolled up give you a score. So it looks at some of those individual issues like the urinary tract, the catheters with urinary tract infection. It looks at it for bloodstream infections. It looks at pneumonias. It looks at a number of things. And so our goal was 0.91. We did really well, 0.65. Next time the goal is 0.8. But again, do you see if we can keep driving that down, that's going to help us have some buffers to get to that best care. CLABSI, central line associated bloodstream infection. That's what a CLABSI is. And it's the observed incidence of CLABSIs, of these central line infections, over what we would expect based on how we document how sick that patient was. So if we basically don't document well, this is again another place that could come back and kind of bite us. We performed at 0.40, where our goal was 0.5, so we are underperforming, we're overperforming because lower is better. We're overperforming in that area as well. So we need to just keep driving that. And then the one that's in the red, which I think is why Deb's presentation will be very interesting and helpful, is that the acute CMI, adjusted length of stay at Galveston, case mix index is CMI. We are at 3.08. And what this basically does, it looks at how ill the patients are, what kinds of patients you had, and what services, and rolls it into a formula to get you to this case mix index adjustment. So we have work to do, you can see, and a lot of work. And I wanted to remind us that while we're making improvements, and I mean, I'm pleased that out of 6 measures, 5 of them were doing well, and actually kind of doing really well in a few of those, but we're working on this. But what's the downside? So is everybody else. So they're all trying to move their scores while we're trying to move ours. So we have to really stay on top of this so that we can meet our goal. Now, equity of care. I wanted to talk briefly about what this is and why it's important. Equity of care, what does it mean? Well, patients are going to receive the same treatment despite differences in, and the word I substituted was ethnicity, but it's really about race. I mean, there's some nuances of ethnicity being a different, but it's about, we don't treat any patient differently well, regardless what their race is, what their age is, what their gender is, what their payer status, their economic status. Once they are our patient, we treat everyone the same. That's what I hope there's some folks from CMC and TDCJ that were able to stream or will be able to watch this, because one of the things that makes me proud to work here is the fact that we do a great job with this. We really think about how do we provide for these patients in a way that they're treated the same as everyone else. So if you think about our offenders, they're getting the same level of treatment that we would be able to give others. So equity is really important. It doesn't rank, it doesn't carry as much weight in the survey, and we're fortunate in that we're first out of 102 academic medical centers. There are a number tied for first, and first is best, but we want to stay there. And so thinking about how do we make sure we're delivering the right care to the right patient at the right time every time, we do that equitably. We don't make any distinction in any of those areas. So one of the definitions is that when you look at equity, they talk about we care for the vulnerable populations. But vulnerable, I'm trying to, and you can help me, I'd love to get feedback. I'm on Outlook. If you think there's something here that could have been more simplified, we're trying to get this simple. So instead of using the word vulnerable, which people may or may not understand, let's talk about who they are. They have life circumstances that make them susceptible to falling through the cracks in our healthcare system. They don't have insurance. They aren't educated about preventive care. Even if they were, someone might not give them an appointment. These are the people who oftentimes, because they don't have access anywhere else, they show up in our emergency rooms very sick. When I was in Wisconsin, they were the working poor, the farmers in the rural parts of Wisconsin who worked hard, made a living, but they weren't able to really afford health insurance. Many of them don't have health insurance, and they can't because they can't afford it. And those who do have health insurance sometimes have insufficient coverage. Ask Becky Korenick, who works with the managed care products. She knows people will buy this and say, but I've got health insurance. Why are you going to, why am I getting this bill for being in the hospital and the bill's $25,000? Because they're lifetime max, or the max per incident of hospitalization, is worth $10,000. So they don't understand that the health insurance product that they bought isn't really going to cover much. And so those are the underinsured, and oftentimes people who aren't really understanding it. And they're also the medically underserved. These are people who can't get in to other offices, other systems to get their care, so they have trouble accessing the system. It may be people won't take them because they're uninsured or have Medicaid. It could be they have language barriers to being able to get access, and they can't communicate what those needs are. They may have certain types of disabilities that make it difficult, if not impossible, for them to get to an appointment. So there are all these special needs that patients have, and we need to realize that we as a system, and we spend a lot of money as a system on supports and guardrails to try to help these patients. And then finally, and you know this because you're out there on the units many times, these are very sick patients by the time they're admitted because they've tried not to come to the emergency room because it costs too much. They're going to get a bill, they're afraid. Now, so these are the kinds of patients that we need to make sure get the same treatment and access to the same treatment that others do. So what are some examples of UTMB providing or assuring equity of care? Well, we try to, if we have a patient who comes into the system, particularly through the emergency room, helping them to get a primary care provider to the extent that we can. That's going to help improve their health. Conducting outreach and education through our UTMB Community Health Program. This is a program that has not only case managers and social workers, but community health workers, specially trained people to go in and work with patients in their home environment to see, is there anything at home that's going to undo what we just fixed in the hospital or in the clinics for them? Are they following the plans we gave them? You know, do they have, if they were discharged with congestive heart failure, do they have scales at home so they can weigh themselves and be able, and know that if they gain 5 pounds overnight, they should probably call the doctor. These are patients who have respiratory issues, and we had one this summer in the dead of the heat, a woman with those types of issues who lived in a home without air conditioning. And she was, David will probably remember better than I, but she was back a number of times to the emergency room because she was in some distress with her respiratory system. So these are all things that our patients struggle with, and in trying to get and maintain wellness. We can also make sure that we're reviewing outcomes of care for consistency among all of our patients, and we do that on a regular basis. Mark Kirschbaum and his team, Dr. Sharma, we're looking at those outcomes of care, and we can stratify. Some people said, why do we have to ask people their ethnicity or learn about their socioeconomic status? It's because we want to make sure we can study and assure that we are giving the same level of care to everyone. We contract with TDCJ to provide correctional managed care to 80% of the state's offenders. That's really extending our access for equity of care. And we're also the anchor for the 16-county region that has been doing Medicaid pilots under the DSRIP program, the 1115 waiver. So all of these work together to make sure that we are delivering a equitable stream of care to these patients. I was going to close this part with one quick story about the lady I just mentioned with the respiratory issues that over the summer, because it was hot and she had no air conditioning, ended up in our emergency room a number of times. At one point, the care manager, and do we have any care managers here today at all? You're out managing. Good. Well, good for that. I'm sorry they couldn't get away, but you know, they're incredible problem solvers. But one of them thought, you know, I wonder if she had an air conditioner, if this would help. And so we put an application into the UTMB Good Neighbor Fund, which I, as the leader of the health system, didn't even know existed till I heard this story, and now it's the recipient of many of my donations because it does such good. But the UTMB Good Neighbor account purchased the window air conditioner for her, and after that, she had not returned. So a lot of the circumstances that we're trying to manage don't happen necessarily in the hospital, but it's connecting the patient to the kinds of resources that they need, whether it's transportation, whether it's low-cost drugs, the things they need to be able to manage their care. That's what equity of care is, managing those at-risk patients who don't necessarily, or oftentimes don't have, access to the resources that many of us do in order to be able to stay well. So what can you do? I should have remembered, which is the point. Treat all patients and visitors with respect. Be aware when someone looks lost or confused. Make everybody feel welcome, regardless. Assure equipment, supplies, medications are available for patients at all times. So Frank's group in purchasing, they help us a lot, conduct timely equipment inspections so we know that the equipment's working well for everyone, providing the interpreters for language and hearing impaired so that they better understand what we're trying to tell them for their care. And one of the things is if you have a facility with languages, one of the things you could do to help is receive certification to assist in interpretation at the sites of care, perhaps where you're working. Seek payment coverage and resources for patients. Emily Gertz from the revenue cycle is here. She has two, I think I remember this right, women that we can refer patients who say they have no resources, and we can get up to 50% of them qualified for some kind of reimbursement based on working with these two resources that we have for them. And if your personal finances permit, contribute to programs like the UTMB Good Neighbor so that we're making a positive impact in our own community and individually can help that patient or those patients or that community have better access to care.
Patient-centeredness is a word. Is it a word? Well, it's the way that Vizient measures patient satisfaction, so we use it as a word in our best care presentations. So we thought that would give us an opportunity to define what patient-centeredness or patient-centered care is. It means providing care that is respectful, responsive to individual patients, their preferences, their needs, their values, and ensuring that patient values guide every clinical decision. That comes from a report from the Institute of Medicine in 2001, Crossing the Quality Chasm. I think they're now the National Academy of Medicine, but there are two words that we highlighted there, respect and response. Respect is one of UTMB's values, so it's a way that everyone can help us meet our best care goals around patient-centeredness. It means walking across campus like a meerkat instead of an ostrich. It's constantly scanning the environment to see if there's someone in need of assistance. I try to do that every day. I caught myself this morning answering a text and not looking up. So I said, oops, not setting a good example. So responsive, there's lots of literature about the patient experience and patient satisfaction that says that all the measures of patient experience and patient satisfaction are really intended to capture responsiveness of the health system. It's how we respond and the manner in which people are treated when they seek our care. When I read that definition, I thought, that really says is the platinum rule, treat others as they want to be treated, instead of the golden rule, treat others as I want to be treated, because that supposes everyone wants to be treated like you do. So we need to make sure that we assess how our patients want to be treated. And that's why we do much of the efforts around patient satisfaction and understanding our patients' experiences. So how do we measure it and how have we been doing? We measure it, as Donna told you, through HCAHPS, and that's the Hospital Consumer Assessment of Healthcare Providers and Systems survey. We do that through a company currently called Press Ganey. The survey focuses on inpatient satisfaction, and we focus on the Galveston campus for our best care initiatives. All campuses are important, but this best care initiative really measures the Galveston campus as far as inpatient satisfaction. The Vizient methodology underlying the Quality and Accountability Survey, which is now Best Care at UTMB, includes 9 categories of questions and 21 questions in those 9 categories. I brought along a copy today of the survey that our patients receive. So I thought it would be a good way to sort of walk you through the categories and questions that are included. So the communication with doctors and nurses is the first 2 questions. The first one deals with a set of questions about nurses. The second set of questions deals with questions about doctors. And you can see that the best response on each of those questions is always. So we measure ourselves about how many times our patients say always when we look at these categories. The next group of questions, questions 8 and 9, are about the environment. How often were our patients' bathrooms kept clean, and how often was it quiet around their room? The next is ask a series of questions about the experience in the hospital. The first couple deal with responsiveness, and that's how quickly did you get assistance when you were going to go to the restroom? The next set of questions deal with patients' experiences around management of their pain while they were in the hospital. And then questions 15 and 16 and 17 ask about medications. Now, there's two places that the HCAP surveys ask about medications. The first one is when you take a new medication in the hospital, did you get an adequate explanation about it from the person that gave it to you? Then you move into the next section of questions that starts with question 18. And those questions deal with transitions, or start dealing with transitions. And what are your plans after you leave? Did you plan to go home? And then ask how well the staff prepared you for your return to wherever you're planning to go. And then they ask you if you got information during your stay about information, signs, and symptoms to look for when you went home. The next session, question 21 and 22, ask about overall ratings. And there, we really strive and look at how many of our patients rated us 9 and 10 in these two questions. I'll show you a little bit about that in a second. And then we move again into another set of transitions questions, really focusing on were you prepared to go home or wherever you were going after you left the hospital. And then another question about meds pops up about how well did you understand the medications when you were supposed to take them when you got home. And then there's some demographic type questions. This is something that CMS doesn't want us to share with our patients before they get it in the mail. So it's sort of embargoed for your use only, but I think it's helpful for maybe staff and others to understand the exact questions that get asked and what patients are being asked to rate us on. So how have we been doing? This is from the right side of this slide is from the Vizient study. Patient-centeredness accounts for 15% of the overall score, and we ranked 21st out of 102 in this year's survey for patient-centeredness. We're already in the top, almost in the top 20. We need to maintain that performance. So this is how we've done over the past few years, and then our plotting of our performance amongst the 102 other organizations at the bottom. So in 2014, we were ranked 14th. In 2015, we were ranked 14th. And then 2016, we were ranked 21st. And you can see on the bottom where we fall in the array of the 102 facilities. So our performance has slipped a little bit, but as we try to improve and get better and compete for patients with other healthcare organizations, they're doing the same thing and trying to do it better than we do it. So we have to double our efforts. This is another way, and we told you that we wanted to keep this simple, but we look at patient satisfaction in a couple of different ways. This is another report from Vizient. This is from their Vitals and Performance report. We get it probably a couple of months after a quarter ends. The most recent data that we have from this report is from quarter 2 of 2016. It may have been included in the Q&A study. I'd have to ask Adam or Mark if it was, but it may have been. But this shows that what I'd liked about this slide is the dashed line that shows our improvement over time. So from quarter 3 of 2015 to quarter 2, we really risen the bar on our performance with patient satisfaction. And again, this is how many of our patients rate us 9 to 10, and that's the percentage. So the performance here was 79.9%. Our target was 80.5, and based on this report, we were ranked 35 out of 132. Now, this isn't the 102 organizations who participate in the Vizient Best Care Study, this is 132 organizations who are members. So it's just a little different view. I can tell you that our most recent performance that Donna showed you earlier for HCAHPS is that 81.6% of our patients have ranked us 9 to 10 in overall performance. So we're doing a little better. I think we'll probably hit that top 20 this year. And this breaks it down sort of by domain, so you can see where we're doing really well and where our opportunities are. The nursing care domain that we talked about earlier, we're ranked 12th out of those 132 organizations. The pain control domain, we're ranked 14th out of those 132 organizations, so almost breaking the top 10 on those two. We did break the top 10 on responsiveness of hospital staff. We're ranked 5 out of 132. And then the doctor care aggregate is where we have some opportunity to do some improvement. And they're 69th out of that 132. So that's about the middle of the pack. Any questions about that? So why is there so much focus on patient-centered? I keep wanting to walk around. Why is there so much focus on patient-centeredness by us and other organizations and the government? Well, first of all, it's the right thing to do. Patients are getting greater responsibility for their cost of care. Deductibles are increasing. They want to be informed about the type of care they're going to get. Reputation becomes very important. We found it in our work around transparency that reputation may be the first part of the patient experience for an organization. So making sure that our reputation, as reflected in star ratings and other things, is as good as it can be, and that our employees talk about our organization as a great place to get care. Another thing every employee can do to help us improve. And then probably the next thing in the cascade of experience is making that first appointment or that first phone call or that first visit to the ER. Why else? Because there's greater transparency of results today. The government has released their star ratings. You can go on hospitalcompare.gov and compare hospitals, look at our performance, other hospitals' performance, and really make an informed decision about where you want to get your health care as a consumer. And then we really think that patients don't only look at the care that they receive and the outcomes that they achieve, but they look, like I said, at the reputation, what other patients are saying. And then it becomes so that every interaction with our system, whether it's from the parking attendant to the non-parking attendant at the ticket thing, or influences our patients' thoughts about their experience in our facilities. So what should you take away, or what did we want you to take away? I think this is Donna's. But I can go ahead. What did we want you to take away today about this? Well, we need every leader in the room to relay this information to their staff in a way that the staff find it most meaningful, using the tool, explaining to people exactly what we're trying to achieve. And, Donna showed you that each quarter we continue to struggle and to stretch to meet the targets to get above 20. The length of stay was the one where we haven't done as well as some of the others, and we've made steady progress in the others. Physician documentation underlies every component of best care, probably except patient-centeredness. I don't know if it does there or not. But when Donna showed you those slides that had O/E after the metric, that means observed over expected. So our observed experience over what would be expected. The expected is driven by what's documented about our patients, and then what's coded, and that becomes our O/E. So the documentation is very critical. Accuracy in coding follows that. We have to get the coding right to be able to get that expected up also. And then our improvements in length of stay, observed over expected, we're focusing on the places that we have the most opportunity. That's our cardiology and cardiac surgery service line, our neurology and neurosurgery areas, general internal medicine, and general surgery. So we'll be doing some targeted work with those areas over the next several weeks to explore their opportunities to improve and discuss strategies that they can help us implement to do better in these areas. We've done lots of things with care management and transition of care to get us to where we are with length of stay, and we have made improvements on one front, but not in the quality and accountability study front. But so the progression of care rounds that nurses are doing every day with their interprofessional colleagues, the high-risk complex care rounds that we have every Tuesday, Wednesday, Thursday to review our patients who need a little extra help. Those things are all going toward helping us get the length of stay down. And now I think it's Donna's turn.
So the last slide I wanted to leave you with was really things that you can do or you can tell your colleagues they can do to contribute to best care. So the first thing I think to get anything to happen is you have to be committed to it. And I can't imagine working in a health system or at an academic health sciences center and not being committed to the very best care for our patients. I think I told you when I first heard the Chancellor's Challenge, my first reaction was, oh my gosh, that's going to be impossible to do in 15 months. And then when my rational side stepped back, I used the visual picture. If I had a patient sitting across the table from me and I'm telling them about what UTMB is going to be like, do I want to tell them that you're going to get pretty good care? It's not quite average, but it'll be pretty good. Or do I want to say, I can tell you with unwavering certainty, you are going to get the very best care possible from everyone you interact with. That's the promise we want to make. Will we ever be perfect? Probably not. But we need to get a whole lot closer to that because that's what our patients deserve. And to get there, we have to commit. Another easy way everybody on campus can help is to warmly greet people that you see that are obviously visitors. And if they look lost, offer to take them there, or if you're so busy that you can't do it, find someone who will be able to do it. But David said, scan the environment, put the cell phones down, and look at the people that you're really passing and interacting with. The third one is one we need to do more work on, and that's speaking up about problems, errors, conflicts, misunderstandings that occur in the workplace, supporting one another to find effective solutions, receiving messages well if I don't think things are going the way it should and I'm worried about patient safety. Don't treat me like I'm an idiot. Instead, treat me as if you're glad I brought that up because patient safety is paramount. And if it turns out that I kind of brought it up, but nothing would have come of it, still be grateful that the person was bringing it up to make sure we can deliver best care. We need to give those messages and we need to receive them well. This isn't criticism. This is about keeping our patients safe. And then avoid workarounds. I love hearing about, and I don't mean to pick on the residents, but I'm going to a little bit because it was, for me, is an enlightening story. We train them how to use Epic, right? They go through hours of training classes. And then they go out on the floor and a more senior resident says, oh, don't do it that way. I've got a workaround. And they do. They know how to work around. But what happens? Think about that. We talk about hardwiring something. It means everybody understands their role. They have been trained to do it, and you do it without exception. Unless you want to raise the issue, we look at it again and decide it's appropriate to make a modification. We were talking about this the other day, and Mary Feldhusen had this great example from when she was a Girl Scout, which that surprised me just in and of itself, but But she said in Girl Scouts they learned about, the spider web, and it was a visual using string. I remember this actually. And if you pull at one piece of the string or a piece of the spider web, it all falls apart. If we're the pull, if we're going to work around something, we have no idea what it's going to do at the front end and the back end. So everything falls apart. So it's everybody's role, all of the training. We need to do what we have learned and not work around, because that's when the system can fall apart, and that's when we get in trouble. We want to work in teams, understanding everybody impacts the patient experience. We also want to demonstrate leadership, and that I call it formal and informal. We have designated leaders. I'm a designated leader with this being the head of the health system. But I really know that out on the floors, out in the clinics, out in the departments, there are people who are leaders because the teams of folks that are out there respect their opinion. So understand the value of your speaking up, of your giving guidance, of you talking about the importance, how far that can go. One thing that's always hard for us is maintaining our focus. Oh, let's do 3 more things today than we happen to plan. We've been trying to stay very focused. Best care is our focus. We have other things we need to do with our job, but we need to do it in the context of delivering this exceptional patient experience every time. Creating and supporting a blameless culture. Sometimes that's hard for people because, especially if we've been trained, I need to do things right. Well, if someone thinks you aren't doing it right, then I want to fight back, say, no, I did. But if something happens, we also don't want to point fingers. We need to remember that unless someone is just being irresponsible, mistakes happen because the system failed, not the person. And so we need to fix the system when we have issues. We need to collect real-time data so that we can begin to find areas for performance improvement and making decisions based on scientific evidence that benefit the patients. We talked about hardwiring, and that is everybody knowing the process, knowing their role in it, and following that, and not reverting back to the old way when the team that's helping you improve leaves and you think, oh good, thank goodness they're gone, I'm going to go back to doing it the way I always did. We need to understand the improvements there for a reason. And then we need to wisely use our resources in accomplishing best care, because there's a cost component to efficiency, and that's where we don't do as well. So we need to make sure, are the resources we're using the ones that are needed? Are we delivering that right care in the right place to that patient? Could we do this in the outpatient setting, not the inpatient? What's the barrier to that? Those are the questions that we need to ask. Everybody contributes, everybody. And so at my Mondays in March, I'm going to put a few people on the spot. This will probably clear out the auditorium, but I'll tell you in advance, where I want to understand who's your customer and who do you impact, and then we'll go till we get to the patient. Because if the patient's at the center of everything we do, no matter what we do in this organization, you impact best care. It may not be in the room, but you impact it. So hopefully this was helpful. I want to ask you, first of all, questions or feedback. You're kind of our trial run on getting this message, trying to make it simpler, trying to make it easier to understand. So let's understand what could have been done that would help that. And if you don't like speaking up in front of people, then email me, email David Marshall, so we can do a better job with this presentation. But now I'd like to open it up for questions that you might have related to best care, the quality and accountability study, equity of care, or patient-centeredness. Yes?
How does our, not necessarily readmissions, and yet they do lead to readmissions from the ER, affect what part of that does it affect?
So the readmissions from the ER, what part of that does it affect? If the patient, cost, right, because we don't get paid. But if a patient shows up at the emergency room and we could have treated them as an outpatient, or we could have observed them for up to 23 hours before they're admitted and stabilize and get them home, that's not a readmission. But if in the emergency room we decide we need to do something and just send them up to the floor admitted and I'll look out, that's what we want to try to avoid if the patient could have been observed, treated, and go home before 23 hours, because that will be paid. What won't be paid is when we make the decision to readmit when we could have maybe done something a little differently. So it does impact it. It reduces our cost to do it the right way, and it avoids a penalty when we do it the right way. That's a great question. Those are the kinds of things I want to know that you or your folks are thinking about or your friends are thinking about, so we can put together kind of an FAQ.
You all know the movie It's Complicated. So while she's trying to make this very simple, my job is to remind you that it is sometimes complicated. So my answer to the question about the ER readmissions is twofold. One thing is the folks at Vizient are getting smarter. So while it doesn't count as a readmission, if we keep them in the rapid decision unit or we observe a patient, it doesn't count as a readmission. This year, Vizient figured out a way to count hours in the ED or hours in observation as another measure of total usage for a patient. So we're not counting them as a readmit, but they're also tracking all the exposure our patients have to us and how we could have prevented that. What I was going to suggest is we've been hearing some really nice changes that are occurring. In family medicine, Dr. Thompson reported that they've opened up some clinic sessions for discharging patients. I should let Dr. Thompson mention that, now that I see she's in the room, to allow patients to have access in their clinics so that they may even avoid getting to the ED. They don't have to see the ED as their place of last resort. And they're doing some similar work with heart failure in cardiology. So we're seeing some energizing and some really good ideas that hopefully can spread in other areas in the organization to avoid some of that readmission activity, even in the ED.
Great, thanks. So the clinics play a big role in helping us do that, even though this is an inpatient view through the quality and accountability study. Any other questions? Those are great questions. No, well, for you shy ones out there, shoot David or me the question. See, not shoot us, but shoot us a question. And I appreciate you showing up. I hope this was helpful. What I really want is feedback. What do we still need to make simpler? So Mary's going to put this up so we can access it through the Best Care website. So if it triggers your mind to look through and say, that part I didn't really get, let us know as we try to make it something that everybody can understand. Okay, so thank you for your time. Thank you for weathering the heat. And hopefully we'll see some of you and some others next week.
UTMB Health, working together to lift wonders.